Thank you so much for coming along, and thank you for BCNA for inviting me. I'm going to try and run through a little bit of early stage breast cancer, and feel free to interrupt and ask questions, or you can ask whatever works for you. So I think just in terms of trying to make things simple, we've got lots and lots and lots of treatments available, but I think the thing that matters the most is if you look at 1991 is when survival is improved the best for breast cancer. That's because screening was started. So the mammograms is what's transformed survival, not so much about how many drugs we use and how much we don't do. The problem is that we still only is about 50% of women actually get a mammogram done, despite all the marketing. So I think it's quite important to remember that. Why do we get cancers? Nobody truly knows, but there's lots of reasons why people potentially get cancers, and you try and target each one of them. The problem that occurs is when you take a biopsy, like a lot of people get biopsies done from the breast mass, and we assume that's what's breast cancer, but even within that tumor, there's multiple different types. So if you look at the picture on the extreme right, so if you look at the picture extreme right, so within that biopsy specimen, there's multiple clones of cancer. So most times when people get chemotherapy, it kills off some cells, but not everything, which is why cancer comes back again, and that's the problem. So there's lots and lots of reasons why people sort of see potentially people might get cancer. So it could be familial reasons, it could be environmental reasons, it could be lifestyle reasons. So if you look at oncology per se, sort of chemo really came into after World War II. So they found nitrogen mustard seems to work, and they sort of working that further, and they found there's more drugs available. But I think of all the things you can think of, a lot of the drugs are pretty much the same for the past 30 or 40 years, but we've been able to get much better supportive care drugs. Like almost nobody ever gets sick or vomits because you got better drugs. You can support the immune system better by giving extra. So those things are different from 20 years ago. So the first true biological treatment that came along with a drug called Herceptin or trastuzumab, probably about 20 odd years ago, and that sort of changed a lot of treatment options for about a quarter of the women with breast cancer. Sorry, it's a small slide, but it sort of gives you a sense of what's happened over the past sort of 20 or 30 years in terms of breast cancer treatment. So lots has changed. So if you pick all breast cancers early stages, you essentially divide them out into, I'll just go to the next slide probably. You divide them out into sort of four main groups. So there's luminal A, luminal B, HER2, and triple negative. If I go back to the thing again, so if you think of the breast, if you look at the last extreme left, majority of the breast is just fat. A little bit of muscle, then there's the lobule that produces milk, and a duct that takes the milk from the lobule to the nipple. That's the breast. So about sort of 70% of all breast cancer is off the ducts, which is so when you sort of see these people talking about IDC or ductal carcinoma, it's a cancer of the ducts. If they talk about lobular cancers, it's a cancer of the lobules. But that's the commonest type. There's other rare types, but that's the two commonest types that tends to occur. And then within that, so there's also early stage. So people talk about DCIS. So that's not cancer, but it will become cancer. That's ductal cancer in situ, which means at some point of time in 5 years or 7 years, that will transform to cancer. It's good to take it out. You can also have LCA, which is lobular cancer. It's the same ducts or the lobules, which ultimately become cancers. And I think what I'm trying to explain with this graph is the more it is luminal A or the more it is estrogen-driven cancer, the less the benefit of chemo. So estrogen blockade is the best way to block it off. If somebody's got HER2 positive disease, block it off with HER2. If somebody has triple negative disease, it's sort of mainly chemotherapy, and now you have immune therapy available. But that sort of covers all the breast cancers you can sort of think of. So people talk about staging of cancers. So staging is different from grade. So people talk about grade 1, grade 2, grade 3. That just sees how nasty the tumor cell is. Staging means where has the cancer spread to. So if it's a small little spot and nothing else, that's probably a stage 1. If it's a slightly bigger slot with maybe a lymph node, that might be stage 2. If there's multiple lymph nodes, that's probably stage 3. And if it goes beyond that, stage 4. So that sort of gives a sense of what, so people talk about, oh, I've got stage 2B disease or 1A, that's all what sort of really means. And you divide it out between T and M, which is the top, so T for tumor, N for node, and M for Mets. So that's how you sort of work out the staging from there. So I guess when you met your surgeon or your doctor, they talk about sort of saying that you have high risk disease or intermediate risk disease or low risk disease. There's a few factors that matter. So one is, what type is it? Is it ductal or lobular? Is it a high grade disease in terms of grade 3 or a grade 1? How big is it? How many lymph nodes are involved? If somebody is very young compared to somebody being very old. So I think you try and work out what the risk is. And when you look at all the cancers, sort of divide them out into three main groups. So something that's estrogen receptor positive, HER2 positive, and triple negative or basaloid. So that's sort of the three main categories, if you like calling it. So when you try and work out a diagnosis, most of it tends to be, majority teams seems to be screen detected, which is when people go to a breast screen and get checked, they'll pick up a lump and hopefully cure it with that. So it's sort of usually 50 to 75, and I think that's changing. That might sort of become a bit younger or might go on a bit older. So I think that might change as time goes along. But the moment somebody actually feels a lump, then breast screen will not pick them up. They have to go to their GP and get a mammogram done. But in terms of detection, most times people feel a lump or a mass in the breast or under the armpit. There might be some thickening, or they might sort of see that the nipples chained, or there might be a discharge. Sometimes people sort of say, I've got a backache, and they find disease in the spine. So there's different ways why people pick up symptoms. In early stage disease, the aim is still cure. It's not just saying, I'll give you a couple more months. The idea is to actually get rid of disease completely and get back to life. So when you talk of types, there's a few more available now. So there's three main things we look for: estrogen, ER. So it should be OR, but we sort of follow the Americans, so that we call it ER. So that's why it's estrogen receptor, progesterone receptor, and HER2. So you can have 2 plus and 1 minus. You can have estrogen all 3 positive, so it's called triple positive. You can have ER and PR negative and HER2 positive. You can have you can have all 3 negative, which is what they call as triple negative. And there's a few more available now, which is low ER and low HER2, but don't worry about those two. That's a bit in terms of an algorithm of how people get treated. So if somebody's got a very small tumor, operate, and that's all you need to do. If somebody's got a slightly larger tumor, then I guess they need operation and they might need chemotherapy. If somebody's got a large tumor or triple negative disease, or they've got HER2, but they might need chemo or something to shrink the tumor down and then operate. So you try and work out what's the best treatment for the person then. So that's a bit of a cartoon of what you might try and end up doing. So we talk about neoadjuvant chemotherapy, or NACT. So some people, you talk to friends and family, they'll say, oh, actually I got chemo first, then I got operated sort of 5 months or 6 months later, which is different from people who get operated and then get treatment later. So if you think of somebody who's got triple negative disease or HER2 positive disease, if you can shrink the tumor down to absolutely nothing, that's your best surrogate marker of how well the treatment is responding. Because once you've taken it out, you actually don't know what you're treating. You're supposing you're killing off cells, but you don't know. So that's sort of one way of knowing what's happening. But if somebody's got cancer that's driven by estrogen, chemo doesn't work as well. So it makes little sense to give chemo up front, when you can just take it out, unless it's a very large tumor and the surgeon can't cut it out safely. Then you might shrink it down and then operate. So how do you pick? Lots of reasons. It could be something as simple as, well, I actually live 3 hours away from the hospital, so they can't come back every week for treatment. Or somebody's got bad diabetes, so they can't feel their fingers and toes already. So you try and figure out what's the best treatment for each one of them. So when they talk about surgical options, I think the commonest thing ends up being the lumpectomy, or a wide local excision, where they just take the tumor out and a little bit of a thing on the side. There's people who get a mastectomy done, where they take the entire breast and the area there. There's also what they call as an axillary node evaluation. So what they do is you can inject a dye into the main tumor and you track it down. pick up the lymph nodes. If the lymph nodes actually, there's no need to go and operate anymore in the armpit, because the lesser the surgery, the better it is. In terms of systemic treatment, you sort of talk about chemotherapy, you talk about targeted therapies, talk about hormone treatment, and there's immune therapy. Now, that's sort of the 4 or 5 main treatments that we talk about. And I guess who ends up getting chemotherapy as such? So if it's a large tumor, if it's a high-grade tumor, if lymph nodes are involved, if somebody is estrogen receptor negative, if somebody's got HER2 positive disease, or they're a young person, extremely young person, or a fit person, it makes sense to give them chemotherapy. So that's just sort of trying to figure it out between the lots that are there. So triple negative cancers and HER2 positive invariably get chemotherapy. If somebody is HER2 or estrogen receptor positive, they may not always need chemotherapy. Some of you might recognize some of the drugs there. Invariably, we will talk about the first drug as the red devil. It's just a red colored drug, it's not, but I think that's what it causes most effective. So of all the chemo drugs, that's probably the most potent drug of the lot, but also causes most of the grief, if you like calling it. So people who lose their hair despite cold caps is usually because of doxorubicin. We had a study last year, we had a study, it was a phase 1 trial. So they've taken the same drug, re-altered it, and I think we had about 7 people on the study. None of them lost their hair on the drug. None of them had heart problems. So I think in the next 4 or 5 years, that drug will become the default to replace that. So it'll be quite remarkable when things come along. Now, a lot of people you sort of talk about end up getting chemo every 3 weeks, but then some people get every 2 weeks, the same drugs. So you hear about people who say, actually, I'm going for treatment every 2 weeks, some go for every 3 weeks. So using that same drug regimen, so the doxorubicin, the American name is called adriamycin. That's where the A comes from. So you talk about I'm on AC chemo, that's the adriamycin that comes from. The cyclophosphamide is the C. So if you're giving it 2 weekly, you're trying to push the person even more. So there's a higher cell kill, you can kill more cancer cells. And that's got a survival benefit that we sort of know of now. And then as we go down further, so there's trastuzumab, is just a fancy name for the drug called Herceptin, which is used for people who have HER2 positive disease. And at the bottom is pembrolizumab or Keytruda, which is used for triple negative, that's an immune therapy treatment. I had to show a graph because it makes everyone look cool, but I think all you're trying to sort of do is, if you look at the top line that's there, so those are people who at some point of time started treatment and you follow them up over the years. So in this case, you follow them for almost sort of 10 years. And on the top is people who are still alive at the end of 10 years. The red line is people who get into trouble for one reason or the other. And the difference is when you give somebody chemotherapy up front, if you can destroy the tumor completely, that's the top line. If there's no response to treatment early on, that's the red line. So there's big benefit trying to knock the tumor off up front. So when you talk about HER2 positive disease, it's about a quarter of all breast cancer, and that tends to make it slightly more aggressive, which is why you want to try and give treatment up front. So we give chemotherapy plus a drug called trastuzumab. If there is absolutely no disease at the end of that 5 months or 6 months of chemotherapy once they operate, then it makes sense to just give the Herceptin alone for a total of a year. If there's still some tumor cells remaining in the tumor that's been taken out of the person, then you can swap the drug to another drug called Kadcyla. Now, why that's important is because if you operate up front, then you don't have access to the second drug. So there's reasons to sort of do it this way, so it makes good sense to use that. If somebody's got a very, very small tumor, which is HER2 positive, it doesn't make sense to give a crazy amount of chemo. So you could probably get operated and just give a small amount of chemo, just the paclitaxel with Herceptin, and that is almost as good as giving the entire lot. So there's no reason to sort of, I think the idea is if you can reduce the amount of chemo, that's ideal. So one of the biggest problems with Herceptin is it can affect the heart, which is why people get heart scans and every sort of 3 or 4 months to make sure. The thing to remember is that first drug we talked about, doxorubicin, the red colored drug, that can cause irreversible heart damage, whereas Herceptin can cause reversible. So if you stop the Herceptin or get a drug on, the heart bounces back again. I think that's important to remember. There's some people who are happy to spend extra money. So I think the first drug called pertuzumab is not funded on Medicare to use it upfront, but there's some people who still want to use it. It's about sort of $6,000. I personally don't use it because I've found that the benefit is relatively little, and it's not worth the money spent because you have access to another drug later anyway. So a drug called Kadcyla, which is available second line if we need it. That's why I can't see a point of trying to spend the money for the first one if this is going to work so well anyway. So we talk about triple negative breast cancer, which tends to be slightly more nastier again. And the thing that sort of occurred really in the past few months is getting access to immune therapy. And I think a lot of that is really sort of thanks to BCNA and their group who've actually lobbied the government and sort of pharmaceutical companies to actually get the drug out for free initially, and later it's on Medicare. So I think that's a big win for a lot of people who need the drug. So again, we tend to give people treatment upfront, immune therapy plus chemotherapy, and then go back and operate on the same. So when you think of hormone therapy or hormone blockade, one thing to remember is it's not to make women into men and men into women. That's quite important to remember because people ask me that. All you're trying to do is block the estrogen. So if you think of it, 80% of all the estrogen in the body comes out of the ovaries. So if you've got somebody who's, 30 or 40 years of age, the ovaries are still working well, you've got to shut that down. So you either shut it down by taking it out, or you can get an injection every month to shut the ovaries down. So I think that's important to remember. You can use a drug called tamoxifen, which works for everyone. So whether you're 20 or you're 100, it works for everyone. The middle three drugs tend to only work in people who are postmenopausal. So if somebody is, let's say, 35 years of age, they still haven't hit menopause, you have to make them menopausal by shutting the ovaries down, then you use these drugs. We don't tend to use fulvestrant very often in the early stage. It's more so for advanced disease that's there. So I think it's important to sort of differentiate between pre or postmenopausal. And I think we tend to define it either by doing blood tests to look at the levels of estrogen and a few other hormones, or if somebody's not had a period for at least 12 months. So that's just a way to sort of shut the ovaries down. So either you can use a drug called Zoladex or Gossarin every 4 weeks. You can get operated, or they can also give radiotherapy and just knock the ovaries off. So what are possible side effects? So in a way, you're creating menopause. So you get all the joys of menopause because of that, unfortunately. So there's hot flushes, there's weight gain, there's decreased libido, there's vaginal atrophy. A lot of people also complain of aches and pains, most on the little joints and the larger joints. Tamoxifen has a slightly higher risk of clots. Some people complain about mood changes. They can also, somebody's on tamoxifen long term, there's a slightly higher risk of uterine cancer. So I think it's important to, if somebody's on it for like 4, 5, 6 years, they should get ultrasounds of the uterus done. For letrozole or exemestane, the other class of drugs, the biggest issue tends to be small joint pain, so it can cause osteoporosis. So a lot of people, what they do is they start with tamoxifen for 2 years or 3 years, and they swap to the other drug by then. So then you know for certain if they're menopausal or not also. So I think most times people give it for at least 5 years of treatment, but the number keeps going. So it became 5 to 7, and then sort of 7 to 8, now it's sort of close to 10 years. So that sort of just keeps going on and on and on. I think that's the problem. And I think the thing is, it becomes a long-term issue, so you've got to remember the side effects that can occur from a long-term perspective. So it's important to have a baseline bone density scan, just to know exactly where the bone strength is. Calcium and vitamin D supplements are good, and I think the single most important actually is exercise, which none of us want to do. That's the problem. There's a new class of drugs that are coming through now, which is this fancy term called CDK4/6, but that's a new class of drugs. So these drugs are funded for stage 4 disease or metastatic breast cancer. but they've actually shown there's good benefit even in early stage setting. And I think at some point of time in the next few months or maybe a year or so, hopefully one of them at least will come on to Medicare. So that way it'll make good sense to get access to them if that's possible. So abemaciclib or ribociclib, either of them are fine. You sort of try and pick up more so from terms of side effect profile. So abemaciclib can cause quite significant diarrhea. So that's the thing that sort of worries me in that respect. Ribociclib doesn't cause that, but it can cause the blood counts to drop down. So each of them sort of have issues in that respect. You also end up doing ECGs with ribociclib because it can affect the heart ECG pattern in some people. Ribociclib. Yeah. So you probably get bloods done every 4 weeks or so. Yeah. The advantage, if you like calling it for ribociclib, if it does come onto Medicare, is that even for people who have no nodes involved, like N2, N3, or N1, or even node negative people with a higher risk disease showed benefit with this. Abemaciclib was only people who had node positive disease. So I think that's the difference between the two. There are ways and means of getting access to it, so it's worth sort of speaking to your doctors if that's the case. We had a trial get access to one of these drugs. So I think we had about 38, no, I think we had 37 women, I think 4 men who got onto something this on the study. So they got the drugs for free. So we talk about radiotherapy. So if you go back about 20 or 30 years or a bit more than that, what they would do is just do a plain chest X-ray of the chest and just zap through and through. It worked, but you sort of drill a hole through. Now what they do is it's more through tangents. So if you look at, for example, the right breast, it's not affecting the heart, it's not affecting the lungs because you're just going on the surface. So you can still protect everything else. Now one of the things that happens is when you think of people who have just a lumpectomy done, they will invariably need radiotherapy. But if, let's say, somebody lives, I don't know, from a country town or lives far away, doesn't want to shuttle back and forth radiotherapy, one option might be to do a mastectomy. I think that's good to discuss up front because that makes a difference to your treatment later. So it's worth sort of thinking about those. So some women who have hit menopause will probably also end up using a drug called zometazoluronic acid. So this is used primarily for people with osteoporosis. But this drug in the early stage is not for osteoporosis alone. It's also actually, if you think of it, if there's any cancer cells floating in the system, it needs to go and sit on a bone for it to do anything. If you can change the environment of the bone, then the cancer cell can't go and sit there. So that's what this drug is doing. So there's survival benefit actually using this upfront. So most times they get it sort of once in 6 months or once in 12 months or about 3 years or 4 years. And doesn't really cause too many dramas. The only thing to remember is that if somebody's on this drug, should not get any teeth pulled out. It's important to remember that. It can cause issues with the jaw. There's some people who are on Prolia for osteoporosis, and you can't really use that for this setting. For some reason, it hasn't shown survival benefit. Yeah, so it's worth getting a dental check done on kidney function. There's another drug called olaparib, which is what they call as a PARP inhibitor. So about 1 or 2% of women will have something called a BRCA, BRCA1, or one of these genetic mutation things that tend to occur. And they found that this drug will probably have some benefit. But I think the benefit is not enough to justify spending crazy amounts. It's quite an expensive drug. It's not on Medicare. I don't think it's going to go on Medicare in the near future. So even though it's worth knowing about it, but I wouldn't sort of struggle to get the drug. So a lot of people ask, can I get genetic testing done? So even though it's sort of an interesting thing to ask, but practically there's actually very few people actually truly benefit from that. So I think the way that I see it, if somebody's under the age of sort of 45 or 40, should get tested for. Anyone with triple negative breast cancers, if somebody has bilateral breast cancers, any man with breast cancer, if there's 2 or more first relatives who've had breast or ovarian cancer, so there's sort of 5 or 6 things who must get tested, but not everybody needs to get tested for this. And it's important to remember that it's not just a blood test, but if somebody's got a mutation, it makes a big difference to the kids, the grandkids, the relatives, so there's a lot to think through. So it's worth getting, so like for example, if I refer somebody to the Royal Adelaide for testing for this, they'll actually have a genetic counselor who goes through all the implications before they get tested for that. Some of you who are with a surgeon or oncologist would have gone through something called PREDICT. So this is the calculator which they made up in the UK, not made up, they made in the UK. So you can then try and figure out what the possible benefit of chemotherapy or hormone blockade is, and then work out the risk-benefit ratio. So it goes based on, what is the age, what's the menopausal state, the estrogen receptor positive, negative. So you go through each of those things one by one, and then they work out what the benefit is. And so you work out if your benefit is 2% and your risk is 5%, you're mad to have chemo. So you try and work out what the risk benefit is. There's some people who like doing something called an oncotype DX, which is a gene panel to tell you exactly what the risk or benefit of chemo is. It's about sort of $4,500, $5,000. And if you think of it practically, most times you can make out clinically what the true benefit is. That's why it's not used very often practically. So when we use chemotherapy, there are problems to it. And if you have to look through it from a bigger picture perspective, there's immediate problems, there's early, delayed, and there's late complications. So the late, most times we don't sort of tend to look at them very often, but there's a risk of a second cancer. So for example, people can have issues with a leukemia or a lymphoma sort of down the track because we're churning the bone marrow. Some people can have issues with sterility, which means the ovaries or the sperm sort of stop getting produced. So just those things to remember about those. So people talk about nausea, vomiting, but very few people now actually ever get sick if you can use your drugs properly. And I think we use a lot of steroids, which buzzes your head for the first couple of days, but actually works very well as an anti-nausea drug. We use metoclopramide or domperidone, which has sort of been around forever. Some people use a drug called aloxi or palinosetron, which is an injection. If you combine the two, you get a drug called Akenzio, which is a capsule you get on the day of the chemo or just before the chemo. The biggest problem is that it causes quite severe constipation. So just got to remember that when somebody is taking those treatments. I found that lorazepam works very well for people who are very anxious or they can't sleep for the first couple of days. Olanzapine is sort of a drug which is really, really good for nausea. Probably the best drug for nausea. It's only funded for people with schizophrenia and bipolar and all the rest of this sort of stuff. And so for the few days you are, so you get access to this drug, otherwise you don't get access to that. Some people complain of diarrhea, so we use capecitabine tablets or fluorouracil, and that can cause diarrhea. So we tend to use gastrostropolovin, and that works extremely well. But I think if somebody's losing lots and lots of fluid and salts, it's important to complain back and get extra intravenous fluids. One of the drugs called paclitaxel we give sort of can cause neuropathy in the fingers and the toes, and it's important to complain about that. And the reason why that's important is because if somebody's going to die in 2 months, nobody cares your fingers are numb or not. You're going to live long term. You can't live with numb fingers and toes. So it's very important to complain about that. Some people use, sorry?
I was just going to mention, in the hospital, when I was in there and my toes started to feel a little bit weird, the girl come and asked me if I had pins and needles. And I said, no, I haven't got pins and needles, but they're not right. And they avoided it. And I found out when I got out of hospital that I had neuropathy.
So I think the pins and needles is sort of almost the nerves crying out saying there's a problem. Yeah. And if you can pick it up early, then you can prevent it from getting numb. Yeah, I was just going to say that. So some people use gloves, which are sort of frozen gloves, and some people put frozen sort of, sorry? I think it probably does, but usually it's not as practical because once you put it on, you invariably want to scratch your nose or you want to eat something and it's just a pain. That's what happens. So we tried, there's some patients of mine who went and got them and they sort of took it off after 20 minutes or so because they wanted to go to the loo or they wanted to eat something. That's what happens. But Um, but I think it's more important to ask the question every time than try and alter the dose based on that. But there are people who use, I mean, if somebody is a diabetic, for example, they've already got some nerve damage, the chances of them getting into trouble is much higher as compared to somebody who's not. People complain about mucositis or stomatitis, and I think it's important that dentures, like, we sort of say open your mouth and look inside the mouth. We never take dentures and see what's happening in there. So I think it's important to remember about those and a good oral hygiene. I found there's a mouthwash which is made, there's a cancer hospital up in Melbourne called Peter MacCallum. They actually make a mouthwash called Peter MacCallum mouthwash. I found that the best mouthwash of the lot. I don't know what they make different, but it's actually really good. We use lots of steroids. We completely muck up your sugars. And I think it's important for those first 2 or 3 days, when the steroids are high, the sugars are very high. So, if you crank up your insulin, long-acting insulin, on day 4 or day 5, after the steroids are over, then the sugars are going to crash. So it's important you're going to hypo then. So it's important to remember that. We're using more and more of PICC lines or ports. Say if somebody's a woman, the other side of 45, cancer, chemotherapy, PICC port, you're a sitter to get a clot. So I think it's important so if you're short of breath, that's new, complain, because it could be a clot in the leg that's gone up to the lungs. That should be treated for early on, should be looked for early on. Some people complain of hand-foot syndrome, so capecitabine can cause these fingertips and toes to get red and warm. The treatment is just stop the drug, it fixes itself, but you have to complain about it early on. So I think ovarian preservation is important to discuss pre-treatment. So at most times, I think it's pretty hard to go and get ovarian preservation in terms of trying to get IVF and whatever else done. But most times we end up using a drug called Zoladex or Gosin just to try and shut the ovaries down or freeze them till the chemo is over, and then you can get rid of that then. So I think it's important to discuss that at least. So there's a whole new class of drugs called immune therapy that's come along. There's sort of quite a buzz about it, but in breast cancer, it's not been as amazing as lung cancers or head and neck cancers or kidney cancers or melanomas, so it's slightly different. So that's probably a simple cartoon. So if you look at the top bit of the cartoon, so you've got the T cell, which is your main immune system, if you like calling it. And when a healthy cell comes along, nothing happens. It sort of stays well. When a bad cell comes along, the T cell recognizes there's a problem and kills it off. That's what should normally happen. Now, if you take that healthy cell, if you take that infected cell as a cancer cell, it's the same story. So all of us in this room here get cancers every single day. The body recognizes they're bad and they kill them off. That's why we don't get cancers. And some people, some cells slowly grow, evade the immune system, and they grow till it overwhelms it. So if you look at the lower one, where the T cell comes up with the cancer cell and it can't work on it, then you use an immune therapy, what they call a checkpoint inhibitor, and that's what activates the immune system, and the immune system fights the cancers. That's the logic of how it works. So what are problems that can happen long term? So doxorubicin or Herceptin can cause heart failure. People can have lymphedema from lots of surgery in the armpit or surgery and then radiotherapy to the armpit, so people get lymphedema. Medication with men for breast cancer, there's really no difference in terms of access. I think some of the men get upset that we're not getting access, but there's really no difference. Everyone can get access to everything. But I think from a practical perspective, for people who live, for example, Murray Bridge is not that far, but it's still an hour away from the city. So it's a pain to shuttle back and forth every day. I think it's important to remember about PATS. I think it's got to be 100 kilometers from where you are. Yeah, no, so because it's not enough, unless you go the other way around or something. But it's important, if you're going to a place that's far away, I think it's important to at least ask the question about PATS, because at least you can get your fuel and all those sorted out. If you're going in to get treatment, let's say St. Andrews or the Royal Adelaide, Cancer Council Lodge, a lot of those things help out with the costs. And I think it's worth thinking about setting up support groups where you are, because it gets a bit hard. Who do you ask questions? Who do you sort of speak to? And I think the BCNA has a good sort of support network, or through the McGrath Foundation. You've got nurses who can try and support you when you're on treatment or even after. In terms of working during treatment, I sort of tend to encourage people to still continue to work, purely because it'll drive them mad otherwise sitting at home doing nothing. But I think it's good to work, even if it's working part-time or doing something. I think it's quite good. So for most of the chemo day centers, the nursing support is quite good, so people can call up and ask questions or just sort of say how things are going. I think for a lot of times, if it's not a true emergency, the nurses will help bring you back and admit you to hospital, just purely to avoid going through the emergency, which is an absolute nightmare nowadays. They do offer sort of counseling services. So I think some of you already had Dr. Trotman, who was sort of, I think she's the next room now. So she supports an absolutely amazing program that she sort of supports people through. And there's Canteen, there's McGrath Foundation, there's BCNA. So there's a whole bunch of other things, but the problem is trying to get access, or at least knowing these things are there. And I've sort of found that the breast cancer nurses or the McGrath nurses actually help a lot of patients to get access to this, or the families to get access to them. I think it's important to try and work through each of these one by one. I've had in the past 6 months, I've had 2 women who've sort of got pregnant, and which has been a bit of a nightmare for me to try and deal. But I think it's a real issue, more so for younger women who want to get pregnant and have babies. I think it's important to remember that. So there's lots of issues with psychological impact of what happens. I think for a lot of times, once we finish chemotherapy and we discharge people, a lot of people get upset because who's going to follow me up? Like in the day center, you can call up anytime, speak to the nurses, speak to the doctor, but once you go back to the surgical team, usually in a public hospital, it's quite hard to get access to actual surgeons. So I think those things matter. Think about bone health, menopausal symptoms, heart function, and I guess the idea is to prevent recurrence in the future. Most times when I finish chemo, I refer them back to the surgeon or the GP, and they would continue follow-up. A few of us sort of set up a research unit up on South Terrace a couple of years ago, and that was purely to try and get access to new drugs or try and sort of see what we can do differently. And I think the idea was sort of trying to get access to newer drugs and newer molecules and getting more options for people. I think we sort of tend to monitor them multiple times, and there's really no cost to the patient or the family. And we sort of use them both for public as well as private, so there's really no cost to anyone. So we're based out of South Terrace. That's a fancy new building that came up, and so we're on the top floor for that. So we do a lot of phase 2 and phase 3 work, but we also do a lot of phase 1. So phase 1 work means including what they call as first in human. We've done it in dogs and cats, and we're moving to humans now. So you get access to absolutely cutting edge drugs, which nobody can get access to even if you had the money. And we just sort of starting off, we've just opened a new study which is looking at telemedicine, or so if somebody lives at, let's say, Whyalla or Port Lincoln or whatever else, so you can video link them and sort of still get them onto a study based on that. So just a couple, so that's the study we just closed a couple of weeks ago. This was the adjuvant hormone blockade study, which was getting access to the other, that we talked about ribociclib or abemaciclib. So one of those sort of drugs where you can get the drug for free. There's a HER2 vaccine. So if somebody has this low HER2, for example, they actually do a biopsy, create a vaccine for that, and you can use that to prevent cancer recurrence in the future. So I think if I can leave you with one thing is that one size does not sort of fit everything. So just remember to ask questions, and just because you're asking questions, you're not offending anyone. Remember to ask. So thank you so much. So that's the BCNA web page. So if you want to sort of look into this, there's a whole bunch of extra resources available there. Thank you.
We've got time for questions. So how cool is that? Oh, just wait for the microphone so people online can hear us as well.
I had epirubicin, and you said heart failure is a long-term possibility. If I'm 4 years down the track, does that mean I'm fine, or that can still happen sometime in the future?
Yeah, most times it tends to occur early on, which you can say when you have a heart scan pre-treatment, you probably end up doing a heart scan late or something else. But if you've had good cardiac function up front, it's very unlikely to cause issues in the future. And there's a maximum tolerated dose in a lifetime of a person.
Can we just, there's another question in the green down front. Just on cardio health, because it has really come, it's an emerging area of evidence. What should everyone kind of be doing to make sure that they are across their cardio health?
Yeah, I think, so like for example, a lot of us end up doing heart scans through what they call as a gated blood pool scan. Some people use echocardiogram, so they end up seeing a cardiologist. If they're seeing a cardiologist, they end up sort of getting proper checks done regularly. But probably the single biggest thing will be exercise. I think, which is again, I know it sounds sort of silly, but that's probably the single biggest difference that we can make to our own health.
Thank you. I'm early stage, just been diagnosed. I've got a DCIS, but it's needed a couple of bits of surgery, and I'm going to have follow-up radiotherapy by the looks. Thankfully, I don't think I need chemo, and just chemo just sounds horrible. Surely there's something better than that these days.
We only use organic vegan chemo.
I think this kind of goes to a very important point around people being part of clinical trials, right, Rohit? And how I think it's the more and more we know about breast cancer, the more we need to try, and the clinicians say de-escalate. I tell them not to use the word all the time because that's not what it means. It's not the intent behind the word, but to actually be much more targeted so we are not increasing people's toxicity for a very small benefit. And I think one of the challenges, Rohit, is around people really understanding what the cost benefit is. Like, what does 1 or 2% mean to me as a person? So what are some of the things you do to explain that to people so they can understand what the benefit is for treatment?
So if you look at that sort of thing I showed you, that predict, that web page I was talking briefly, just that thing that's there. Now, it might talk about, let's say, a 2% benefit, for example, if you look at 5 years from today. But the hope is you're not going to live just for 5 years. It'll be for 10 years, 15 years, 20 years. So in 15 years' time, that 2% might actually be 6 or 7 or 8%. So when you think of 8%, it doesn't sort of sound like a big number, but that's 8 women or 8 people. That's a big number. For each one of those, it makes a difference. But I think the idea would be what they call as de-escalating. So you're trying to reduce the amount of toxic stuff in the bigger scheme of things. If somebody's got cancer driven by estrogen, the single most important thing is hormone blockade, not chemotherapy. I think that's important. But similarly, I sort of spoke about if somebody's got a small tumor which is HER2 positive, there's no reason to give doxorubicin. You can just get away with paclitaxel with Herceptin for a shorter time. So the amount of, if you like calling it, damage to normal cells is minimal.
There's a question at the back.
Yeah. Hi there. Thanks for your talk. I just wanted to ask, I got diagnosed with high-grade DCIS, and I'm still waiting to go and see the genetic cancer clinic at the RA. My surgeon discussed, having tamoxifen, and she said that it could be, up to 50% benefit of prevention of any other breast cancer in my remaining breast. But she said, the risk of getting breast cancer in that breast, what is it? We don't know what that is, because with DCIS you don't do any hormone testing, or you don't at all. I just wanted to know, is there any, how do you then work out? She said you could be getting a 50% reduction of 2% chance of getting, or you could see a 50% reduction in 95% chance of getting cancer in that remaining breast. So
tamoxifen can be used as a preventative drug, if you like calling it. There's another drug that you can sort of use, but it's just that's probably where your surgeon's coming from. But from a more pragmatic perspective, if they've taken the DCIS out completely, and as long as you're getting regular checks done, the chances of getting something is lower. The problem that occurs is the younger you are, the denser the breasts are, and the harder it is to pick up stuff on a mammogram. So when you're combining a mammogram with an ultrasound, you pick up a bit more. The ideal test is an MRI. The problem tends to be about, one is funding MRIs, but also getting access to MRIs, but that would be ideal.
There's a question down here. And in actual fact, I was with a friend, and I was also telling someone to keep, even if you were diagnosed quite a while ago and you didn't think you had access to MRI, you may now have access to MRI in some situations because we've been able to advocate for that access to be broadened. So don't just assume what was happening in your surveillance 10 years ago is what you should still be having. So asking those important questions in surveillance and what's best for you is really important.
I'm on exemestane, and I think I started on letrozole swap because of this one suited me better. And at the time I was told I'd be on it for 5 to 10 years, depending on what the new news was. Why would it even stop at 10 years? Why isn't it for your whole life? Not that I'm enjoying it. But I just don't know how you pick a time.
So if you look at, so if I have to pick something, let's say like, I don't know, let's say gastric cancer or pancreatic cancer, like metastatic disease, sadly in a way it's easier to pick up survival data because people die earlier. So if you have 100 people diagnosed today, within the next year or 2 or 3, you will actually get survival data. And you know exactly what to do because you know what's going to work, what's not going to work. Thankfully, breast cancers, people live forever to some extent. So if you look at the first tamoxifen data where tamoxifen actually works or not works, I think last year before that they had the 25-year update of survival. It's taken 25 years to know that one drug probably works well. Then letrozole and all came along about about 10 or 12 years after that came along. And you've got data for that too. So you don't have longer term data beyond. So I think the 10-year mark is what they think is probably adequate. But it's also saying that you've got new drugs coming in now. So mixing that. So for example, ribociclib has got 3 years data for, if you add 3 years, there's survival with that. Abemaciclib is 2 years. But you don't know what's going to happen for the future. The other thing is that these drugs are not without toxicity. If you had no toxicity, like for example, if you got blood pressure, just keep popping a pill, you're fine. But it's harder for drugs which cause problems.
Stay. Yeah. We've got time for one last question.
My oncologist, in answer to that question, the way my oncologist simply put it to me was that the new data, and data's changing all the time, she said the new data shows that there's no further benefit beyond X number of years. So something I thought I was going to be on for 5 years, I ended up being on for 3 years because she said the data said there's no further benefit in terms of statistics beyond that, so might as well stop it. But my question actually was relating to the slide on the genetic testing, and it had some criteria for that genetic testing. Is that government-funded genetic testing, and how do you access it, and how much does it cost?
So you can get tested both public and private. So just to get a consult, just to go and speak to a genetic, like there's really only one proper genetic oncology person in the state. So I think there's about 3 or 4 of them who work at the Royal Adelaide now, or through Carlin. So I just tend to refer everyone there, and they'll see them in, if somebody is important, they will see them in time. And the reason why that is because the actual testing, the initial testing is not very expensive, but if you have to do germline testing, that can be very, very expensive. And if you get it to the public sector, all of that gets funded through to the taxpayer. But otherwise, if you just have to go and get a blood test, and probably around $400 or $500.
So how do you access that?
Through you can get it done.
Through your GP? Or?
No, it'll probably be through the genetic person, the genetic oncologist, or potentially even your oncologist.
Yeah. So talk to your oncologist first. They will run through a series of questions to be able to determine if it can be accessible by public, like if it's meeting the criteria. If it's not, then you'll have a conversation about whether you still want to do it, what are the benefits, what are the costs, and then what are the actual costs to being able to do it. So it will depend on different criteria for people around whether you have access or not. I just want to have one last question because it drives me a bit mad. This 5-year thing. it only seems to matter to clinicians and researchers 5 years, but now we seem to be in this kind of world of celebrating it 5 years. How did they ever come up with 5 years?
Okay, so if I
He's going to kill me.
so if I look at something more, let's say chemotherapy. Okay, now most people get 6 months of chemo. Why 6 months? There's no law. They just picked a number. Because I kid you not.
I know.
So 3 months sounded too little. 12 sounded too much. They just picked 6 months. So if you look at the original, so if I go back, I don't know, let's say I go back 10 or 12 years ago, there used to be a regimen called CMF, cyclophosphamide, methotrexate, and 5-FU. That was the 3-drug regimen. Then they removed the methotrexate and put A, which is doxorubicin. They took out the F, which is the CF. It became AC. That is what we use now. So that used to be 3 months every 3 weekly for 4 lots. That's become 2 weekly, that's become 2 months. So actually chemo tends to be for 5 months now. So that's changed only in the past 5 years. The 5-year mark was picked. So originally I think the thing used to be sort of 2 to 3 to 4 years, what tamoxifen. Then they sort of did the tamoxifen versus anastrozole, letrozole data, and they sort of found that 5 years they just picked a number, and 5 years sort of sounded good. And then I think now they sort of feel that it probably is going to be longer. And I think to some extent, I think what will happen is if you look back, if you look in the next sort of 5 to 10 years, cancer is going to become a chronic disease. So hopefully nobody would die of cancer as such, but they just keep popping up till I get something done. So a lot of the chemos will switch over to targeted drugs. It'll become subcutaneous drugs, not intravenous. And that's what will just keep people going. I think that's what will happen as time goes along.
So really they just had to choose a number to start with and then we keep proving it or disproving it. Correct. Please thank Rohit because he needs to go next door.